So I'm going to talk about some of the innovative ways that we can use social media and a bit about artificial intelligence towards the end of the talk. So, there we are, there's Alexa. So we have progressed. I mean, as Jamie said, there's an exponential rise in the use of not just the internet, but more recently in social media. And if you don't engage now, you are going to be left behind. We, in this audience, are not just baby boomers, we are the dying boomers of the next 30 years. Sorry to tell you that, but we are all mortal, and how we use social media is going to affect the way we grow old, be cared for, and eventually die. So, I'll whiz over that slide. So one of the, Jamie talked about social media in 10 years ago. This was a great paper from 10 years ago called Take 2 Aspirin and Tweet Me in the Morning. So it's 2009, so 9 years ago now. This article was about a really innovative health centre in Boston called Hello Health. It was developed by a doctor, a GP, or in the States they call it family medicine, which is probably what we should call it here, a GP called Dr. Parkinson, and I quote him from the paper. He said, healthcare can be simpler, more elegant, and more fulfilling, a more fulfilling experience for physicians and patients and nurses and everybody else. And he opened Hello Health in Boston, where they use social media, they use Facebook, they had video consultations, and it's still going, it's huge in Boston. And they were one of the first practices to start to use social media in a way to reach patients and to reach more patients in an innovative way. So this was a classic first paper of social media and health. So I wanted to step back a bit and talk about the anxiety that we all feel about death and dying. I did remind you earlier on that we're all going to die. That raises the anxiety in the room. So if you work in palliative care, we have reminders of death and dying around us all the time, and perhaps we take for granted that or if maybe it becomes normalised, that anxiety that people feel when death, dying is mentioned. If you ask 100 people, I've never done this, what image comes into their head when you mention the word hospice? What do you think comes in? I've done this informally.
Coffins.
Coffin.
People in black.
Yeah, coffin. I've asked lots of children who have actually had experience of the hospice. And in fact, I'll never ask children again for advice, because when we built our new hospice, we have a children's support room. And I asked a child whose dad we had recently cared for, I just remember her name, Hope. I asked Hope, who's now 17 but was 6 at the time, what picture should we put on the wall in our children's support room? And she said, a coffin. I didn't take her advice, and I've never asked children anything else since. So, death anxiety. Now, one of my heroes is a guy called Sheldon Solomon, a professor in New York who has studied death anxiety, particularly after 9/11. He looked at what New Yorkers did when death anxiety was raised in that great city. And what he found, his research and other people's research, is that people started to communicate more, both on social media and in voluntary groups. They did lots of other things too. They drank more, they bought more Bibles, so faith became more important. People volunteered more. What else did they do? They became more patriotic, which isn't always a good thing. But basically they connected more, and that's because it raises self-esteem when we connect with other people. That's why loneliness is so bad for you. So my view of how palliative care works, these are just 2 books if you're interested in death anxiety. The worm at the core is Sheldon Solomon's book, and Staring at the Sun. I am whizzing through. So my theory about how hospice and palliative care works is that we reduce the anxiety around death and dying by promoting self-esteem in all of the work that we do, but also by promoting connection, whether that's connection with community or connection within families, or connecting people with the things that matter to them. So connection is important. So we need to provide opportunities for connection and self-esteem building, and we do that. So I want to talk about connection, and I'm particularly interested, and I will dwell on that in this talk, how we connect our professional circles with our social circles. So the green and yellow blobs are the professional networks we work in, whether that's a hospice or a comms network, and the pink and purple is the networks that our patients and families are engaged with or network to. And actually those two circles don't communicate very well. There's big barriers between them, and yet we could learn much from each other. So 6 ways of connecting. The asterisk ones are the ones that I'm going to speak about mostly. So you can look at the ways professionals link to professionals, i.e. to each other, to the public and to patients. And you can look at the way that patients link to the public, to each other and to their communities. So I'm going to look at some of the best examples where social media has helped these connections. So if we first of all look at how we as professionals, I'm talking about healthcare professionals at the moment, how we engage with the public. Now Jamie's already mentioned, and I haven't even included Snapchat. I'm going to talk about WhatsApp later because that's a particular interest of mine. We engage in many different ways now as professionals. This is me looking 10 years younger, or 20 years younger maybe even. And I've really enjoyed being on Twitter and learnt loads. And 3 of the Twitter stories from my analytics that have had the greatest number of, perhaps the biggest impact. This was a picture in the hospice where I used to work of Peggy. Peggy was dying, only had a few weeks to live in this picture. Her granddaughter was pregnant, Natasha, a policewoman, and Peggy wasn't going to live to see that baby born. Natasha, the granddaughter, noticed that we had an ultrasound machine in the hospice, and she asked if we could use that ultrasound machine to show her unborn baby to her grandma. That's one of our doctors in the corner. And we did that, and it was really moving because Peggy, even though she'd been mildly confused, became really animated, and it meant a great deal to Natasha. So this story always makes people cry, so I thought I'd make you cry at the beginning of my talk. And it got loads and loads. I was quite a novice on Twitter at the time. It got loads and loads of, it sort of went global. And I don't know why that is. But it was a human story, and perhaps hospice care is about creating memories, and this was creating a memory in action. We did have an ultrasound policy at the hospice, and it didn't say anywhere, use your ultrasound machine to scan pregnant visitors. So we broke a few rules, and nothing bad happened, even though some of the risks were worse. So that was Peggy. This was another really simple picture that also got, and this was Marion. Marion gave me permission to tweet a picture of her in the local hospital a few days before coming to the hospice, and then a few days later in the hospice, dressed, hair done, smiling. This was a very, very simple photographic way of communicating a hospice message. And this is more recently, one of the rules I broke. I'm currently working at the Royal Marsden Hospital, where cats don't usually visit the hospital. And this is Peanut, who visited Isabel in the last few weeks of her life. And on those days that Peanut visited, Isabel's pain requirements went right down. Staff felt calmer, apart from those who were phobic about cats. But Peanut just sat quietly in the corner. And we tweeted all about Peanut. Interestingly, the Royal Marsden brand is about curing cancer. So they're really, really nervous about tweeting stories about dying, even though we think those are good news stories, and that people who are being treated for cancer need to know that if things don't go well, they will be well looked after. So I'm working with the comms team there, but they were a bit nervous about this. Tweet, the other way that professionals talk to the public now is openly tweeting at conferences, and I do that a lot, much easier than making notes once you get into the hang of things, and there's a slide here with top tips for tweeting at conferences. But I have tweeted, I sit at home and I feel that I'm at a conference in Australia or in Boston or anywhere where you can see what other people are tweeting and you can retweet and learn. And all you need to do is know what the hashtag of the conference is. And in fact, we're here today. As we know, the hashtag is Life and Death Online. If you put that into your search engine and then click on latest, it'll give you the running scroll of who's tweeting from this room now. Who's tweeting at the moment? Excellent. Right. Shall I carry on? Yeah? Okay. I'm going to see Hamilton, the musical, tomorrow. Anybody seen it? No. Yeah, I'm very lucky. But in one of the first songs, it says, talk less, smile more. Sorry, I'm talking quite a lot. Okay, so we talked about professionals. Right? Yes, professionals to the public. What about patients connecting with the public through social media? This is huge, and we are all learning from what patients are saying about their experience. So I think Claire has already mentioned the amazing Dr. Kate Granger, who died, nearly 2 years ago now. She used Twitter, particularly. By the time she died, I think she had 50 or 60,000 followers, and she used Twitter to launch her campaign about health professionals introducing themselves appropriately. But what's also interesting, Kate used Twitter to document her whole illness trajectory. And there's a very interesting, very recent paper. I think Kate invented the hashtag Deathbed Live, where a team have analysed Kate's tweets and to see what sort of trajectory they fit into. And of course she tweeted, I think, right from diagnosis, although this paper looks at the last 6 months of her tweets and looks at recurrence, treatment, further recurrence, more treatment, and then her dying episode in St Gemma's Hospice in Leeds. And we are going to learn more and more about patient experience from looking at social media, blogs and tweets and Facebook posts from patients themselves. We're going to learn more than from conferences and lectures. This is a website with the best cancer blogs. I know cancer features a lot in my talk at the moment because that's where I'm working at the Marsden. The best cancer blogs, and there are some extraordinary blogs around. This is actually an article by a doctor. This is The Atlantic is an American, is it equivalent to The Guardian? I don't know, but it's an online magazine. What it's like to learn you're going to die. I learn a huge amount from seeing people's tweets and looking up the links and reading. I don't know if I spend 4 hours online like the people in the Philippines, but probably about an hour a day, mainly while I'm commuting. Used to be more, and it is quite addictive. But people often say, well, how do you know so much about what's going on in the world? And it's mainly through Twitter, I'm afraid. So there we are. Now, a patient, I'm talking about patients and what they're teaching us. Eamon was a patient of mine at St Francis, and he was already blogging before I met him. And he did a great blog, which you can still find online, called The H Word, which was about his fear of coming to the hospice, and then his experience when we helped control his pain. So Eamon is no longer alive. He died about 3 years ago. I'm still in touch with his wife, and I use his blog a lot to talk about fear of hospice and palliative care. He also did a blog about his bucket list and what he was going to do before he died, but he also did an even funnier, more interesting blog about his bucket list. And this was a blog about what he wasn't going to do before he died. And I don't think we should wait till we're dying to do a bucket list. So we all need to go home today and decide, I am never going to empty my dishwasher again. Bucket list. So that's Eamon's blog, and you can look that up. His blog is actually called Who the Hell Does He Think He Is? I don't know why he has that title, but that's his blog if you want to look it up. So, another blog I learned a huge amount from, another young man who's no longer alive, was Nicky Boardman, who wrote about his experience with colon cancer. And really, it was actually quite hard to read. So he wrote his blog and he tweeted every update. And that, again, was in my early days of Twitter and got me hooked. This was another, I tweeted this, but the patient or the patient's family, a young man called Mo, died in the hospice, and they created an M with candles outside his bedroom, and they were tweeting it and I retweeted. So just, we're learning so much from patients and their social media posts. This is the last one in this section. This got quite a lot of publicity. I can't remember what NPR is. Is it a television station or radio station? TV? Don't know. Okay. So Scott Simon tweeted live from his mother's death in intensive care. And it was quite graphic. He tweeted as her breathing was changing, tweeted about every injection she had, and this got a lot of publicity. This is about 5 years old now. I don't know how helpful this was, but if you think that most people don't actually witness a death till they're in their 50s, unless you work in palliative care, of course, this would have, maybe it would have reassured, I hope it would have done, reassured people who didn't know what was coming and might have had a relative dying. So what are the connections? Patient to patient, and this is huge. Something like, in my experience, 50% of my patients now are on either closed or open forums about their particular illness, and getting much more support from patient peers than from us professionals. Hard to say, but probably true. So this is one of the earlier ones that's got a huge following, Beating Bowel Cancer. And there are quite a lot of Facebook closed groups, a patient, particularly for rare tumours, where people are trying to find out trials that are going on elsewhere in the world, or who's been helped, or who's the best, which is the best hospital to go to. So epithelioid hemangioendothelioma, that is a very rare tumour. Probably only 100 cases in the world at any one time. I was looking after a young woman with this illness, and her mother and her were on this closed group, and they heard about a trial in Germany, which the patient then was eligible for. She went to Germany, and she is now doing really well with a drug that isn't available in the UK. So this is a way of discovery, and I think patient forums are growing all the time. And I think it's really important as healthcare professionals to ask people where they're getting their information from, and are they involved in any forums. and to actually recommend people look on the internet for forums about their particular illness. There will be crazy advice on there, but you hope that they might bring that back to you to help moderate it. And most of these illness-related forums are actually moderated, particularly if they're run. So this is the Rare Cancer Support Forum. They are moderated, so if somebody says go out and drink a glass of concrete every day, somebody will maybe notice that, I hope. There we are. So professional to professional. So how do we as professionals share information with each other? Well, how many of you in this room use WhatsApp socially? Right, that looks like about 90%. Any of you use it professionally within your, because you've been told not to? Or you don't use it for handover or sharing de-identified patient information? Right, well you are very unusual then, because this is a study, a fairly recent study, looking at smartphone use by nurses and doctors. And it showed that over 95% of nurses and doctors use a smartphone, often at work, and over 35% of them are using WhatsApp to share information. So junior doctors sharing handover information, not mentioning patients' names, but talking about a lady on X ward, have you seen her X-ray? Do you need to do a new blood test? So it's absolutely epidemic at the moment, but most of you probably know that the General Medical Council is not advising the use of WhatsApp to share medical information, sadly. Anybody know why that might be?
Not secure.
Even though it's got that encrypted end-to-end message?
Isn't secure.
Well, probably the messages are secure, but who owns WhatsApp? Facebook. And there's small print somewhere that Facebook obviously has access to all of your WhatsApp messages. I don't know if you know that, but so that's a problem in terms of GDPR, because it means that this information about patients could be accessed by Facebook. The thing is, if you de-identify that information properly, it's probably as safe as it could be, and it's going to be an awful long time before people stop using WhatsApp in the way they're using it now in hospitals. I mean, in the Royal Marsden, the junior doctors have a group and share handovers. We've got a palliative care group. So we share articles to read, but we also share urgent messages about rotas, shifts, and anything that needs to be done urgently for a particular patient, and try very, very hard not to identify that patient. So this just reminds us that 1/3 of UK clinicians are using WhatsApp or a similar messaging tool. It's free, it's simple, it says it's secure, reliable, well, it offers a secure, reliable messaging and calling service. But you're going to have to learn to unlove it. But I don't know how it can be policed, because there isn't a better alternative at the moment, although many are being developed. I looked at one last weekend in preparing for this talk called MedCrowd, which a few hospitals are using. It's really clunky. It's nothing like the simplicity of WhatsApp. To create a group takes about 10 steps. It's just awkward, but I think there will be apps developed that allow safer patient or professional communication if WhatsApp is not going to be encouraged. Anybody got any other apps that they use within? How do you communicate with colleagues?
Email.
Email, through NHS Net? Yeah, okay. No apps?
No.
I use Telegram.
Telegram,
which is an
okay.
alternative.
Yeah, so maybe Telegram will just rise in popularity.
Or text. We use text.
Do you think texts are safe? Do you think telephones are safe? Every time I ring anybody, particularly a corporation, it says, your call might be recorded for security purposes, training purposes. So more of our telephone messages are recorded than any of our WhatsApp messages or texts. I'll talk a bit about consent and documentation in the next section. And the question I would always ask, until there's a better alternative, is what's more unsafe at the moment? Using WhatsApp or not sharing vital information? And that's the way that I look at risk as I've got older. Asking what's the worst thing that can happen? You know, sharing a post that the lady in bed 8 in a certain hospital needs more laxatives for her constipation, or not sharing it, and then her being really uncomfortable. You know, we can always pick up phones, but the thing about WhatsApp is it shares with a lot of relevant people in the group at the same time. So it's not one-to-one, it's one to a group. So I'm a big fan, as you'll hear about more in a minute. So that's peers to peers in the professional world. What about patients and their friends, family and community? How are they communicating? Because we all want to spend most of our life outside hospital, particularly when you're ill. But in order to do that, we need to communicate with a lot of people. And at the moment, healthcare is really fragmented. Families are spread all over the world. And people are often involved with multiple agencies. And we think that everybody communicating, so I don't know if anybody's had an ill relative and you've used the WhatsApp group to look after them?
Yeah.
Yeah? Okay, was that useful?
Mm-hmm.
Okay, so what you're doing, you are living that picture. You are linking everybody up around that ill person and sharing what's important, whether that's who's going to cook tonight, so-and-so's a bit more confused today, who's visiting today. And this is going to be absolutely vital in terms of light touch for more community support. So we would be encouraging patients to set up these WhatsApp groups around them, families and patients, in order to share information in a really efficient way. There are professional apps beyond WhatsApp. There's one that Carers UK developed a few years ago called Jointly. I tested it out again. I pretended that my cat was the patient, and I linked in my kids and my neighbour. I think the cat would have died after about 3 days because it's okay, and I do know people who are using this well. It's sort of like WhatsApp. Everybody who's relevant to the care of that person or that cat joins in, and you remind each other what needs to be done. And actually, once you get used to it, Jointly does work well. I don't know. I need to find out from Carers UK how many people are. I think it's very cheap, but you do have to buy the app. Yes, we stopped feeding our cat after a while. We didn't really, but the messages stopped. So what about WhatsApp in terms of, we've just heard that people are using WhatsApp groups to care for each other, and we've heard from Jamie about the massive increase in the use of WhatsApp. So very recently, I'm doing a day a week back at the hospice. Toby, and actually that is his real name, Toby was a single man living in a very small village in Hertfordshire, and he had an illness, and he was quite a loner, but he did go into the local pub a lot. And the two ladies who ran the pub, who are called Rebecca and Lisa, once they heard that Toby had a diagnosis, they decided that they would become Toby's support mechanism. And they set up a WhatsApp group that involved 30 people in the community to look after Toby, and it was called the Care of Toby WhatsApp group. And I've seen a printout, they printed out for me months, because you can print out WhatsApp narratives, and it is an amazing story of community support. They did everything for Toby. They took him to, he had no local family, and was living alone. They took him to hospital, they cooked him meals, they looked after him as he was deteriorating, they organised a rota to visit morning, afternoon and evening, and some people by the end of his life were staying overnight to make sure that he was safe. And I think more and more, if we talk about community engagement, this is going to happen. So it's sort of grassroots up. And probably most of you don't even know that this is going on with your patients and families. So I would find out how they, who's in your network and how do you communicate with them. Oh, this is just one of Rebecca's. She WhatsApped me and she was going to print it out for my research into what makes up community spirit. And there are other apps to support people in the community. Anybody ever heard of the Casserole Club? Yeah. So this is quite an old one. I think it started in Australia, where it simply links up people who like cooking and people who need a meal. Unfortunately, you need to be ill to join this. And it's all done by text, possibly done by WhatsApp now, I don't know. I haven't looked at it for a while. But it sort of counteracts loneliness and it counteracts poor nutrition. So it links up people in a certain neighbourhood who would cook an extra portion and take it round to somebody who lives alone or is frail and not eating well. And it's just a really simple idea about how social media can connect up. I don't know how active it is in the UK, but I think it's a really great idea. It's certainly big in Australia. Okay, so this is a particular interest of mine. I'm going to have to speed up now. How, as professionals, we link to patients. And I've been particularly struck about what I said before, about how fragmented community services are. So, and I've said this before, why don't we connect professional circles with social circles? And you'll probably have lots of questions about confidentiality, etc. So I've been using WhatsApp to support patients and families after they leave the hospital. So Elena, which isn't her real name, was a lady who came to the UK for cancer treatment. Her daughter lives here, and she went back to Kiev for the last 6 months of her life. And there is no palliative care in Kiev at all. There is access to medicines, but there's very little general practice, and there's certainly no palliative care. All there is are anaesthetists. And so Elena's daughter said, could I support her by WhatsApp, using my mobile and her daughter Alla's mobile, and I provided 6 months of support during the last 6 months of Elena's life. And there's a few more messages, and eventually Alla died last summer. But she had almost no other professional support other than instant WhatsApp messaging from me, and it sort of worked. So that gave me the idea, plus a few other cases, to support complex discharges from the Royal Marsden Hospital. And many people who leave the Marsden are not yet engaged with their local hospice or palliative care team, so there's a huge peak of anxiety leaving this well-resourced, well-staffed hospital, going home with lots of medication, lots of symptoms, facing an unknown future, stopping chemotherapy, till they get engaged with their local team. So I have used WhatsApp to bridge that gap until people feel safe in the community. And it's worked well. I've supported probably about 10 complex discharges now, and the conversation I would have with the nearest carer or family member, or sometimes often actually with the patient themselves, is would it be useful to keep in touch via WhatsApp to support you through the next few weeks? And everybody says yes. And actually I then have consent to communicate. And everybody knows the risks of WhatsApp because, you know, we all use it knowing those risks. So this was John, who was discharged from the Marsden to a flat in the East End. One daughter was in Dubai and another daughter was in Australia. They did arrive for the last few weeks of his life. But we kept them informed about how John was doing. The GP was also in this group too. He was happy to share his mobile, and we were all in a group together with John and his family. And I asked them afterwards, how important was it? And they said that it was a real support mechanism, and we thank you for the opportunity. It should definitely be part of the discharge criteria. I now have to persuade the Marsden. But they were less worried about consent, because actually in order for you to share your mobile and a patient's mobile, there is mutual consent. Now, you may ask me questions about, I've now got patient data on my personal mobile. After people have died, that gets deleted. It's obviously not deleted forever, because we know that there's always a footprint. But we're just making it as safe as we could. And I think the consent thing is a big issue. In the future, I hope that every NHS employee will be issued with their own work smartphone. How many of you are given a work smartphone? Okay, because if you are, then this really isn't an issue at all. It's just a way of communicating. Somebody's got a question.
Did you have any ground rules for, you know, what time and when you would be likely to respond?
Okay, so I think some of these are the ground rules. So any communication on the phone is asymmetric. I can choose to answer it or not. So when I set it up with a patient or a family or a carer, I say, look, I've got my phone on all the time. If a WhatsApp comes up and it's easy to answer, I will answer it immediately. But sometimes I'm not looking at my phone, and overnight, unless I'm on call, I won't look at it. So those are the rules. But what I would also do is tell that family where to get urgent advice overnight. It's routine, it's normal, it's never been abused. If I don't answer WhatsApp quickly to an emergency, and people go elsewhere. So yes, I've got rules of engagement with the families, but it's never been a problem. And just like with a phone call, if you phone a patient or family, after that phone call, you document what you've discussed. And similarly, if I have a WhatsApp chat and have advised on a change in medication, I document that chat in the patient record. So there is no issue. And sometimes I can actually print out the WhatsApp or take a photo of it and stick it in the electronic record. So documentation isn't an issue. Consent isn't an issue. Safety or security might be an issue, but patients and me are taking that risk. So that's work that I hope to research properly. In the future, maybe it won't be with WhatsApp, but the advantage of WhatsApp is that everybody knows how to use it. Good paper, there's papers coming out all the time on confidentiality. Confidentiality has to be balanced with the risk of not communicating, and that's a real message that I'd like to share. So I've talked about consent. Power. There was a great conference a couple of weeks ago, about a month ago, on power. Most of our patients, when we meet them, are powerless. You lose all your power when you are diagnosed. You lose your work-related power, your social power, your communication power. So if we can give bits of power back to patients by communicating in normal ways and being available, then I think we're doing a good thing. I'm really irritated that I can't communicate with my GP, not even by, let alone WhatsApp. I can't even email my GP or get through on the phone. And that makes me want to change practice to a practice that's more accessible. So in the 21st century, I think people want accessibility and simplicity. And just in the last few minutes, I'll mention some research that was done again at my old hospice. Danny Miller is an anthropologist in London. He visited, I think, about 50 people who were patients of the hospice. He mainly visited them in their own home and talked to them about how they were using social media during their illness. And what he found was that as people's physical condition deteriorated and they could get out less, their social media use, mainly on Facebook, because that was his particular interest, increased. And that fits with the whole connection thing, that in order to maintain your self-esteem, you've got to connect. So Danny's key findings: people use more social media as their condition declines. But also, he was really struck by this healthcare obsession with confidentiality versus a patient's belief that they want their information shared and they don't want to tell their story a million times. And actually they think we are sharing relevant information, and they're shocked to hear that the hospital and the hospice don't share records. So we're living in a very strange world. And I've been lucky enough to meet Dame Fiona Caldicott, who set up the original Caldicott confidentiality guidelines, and she said she never meant her guidelines to stop people sharing relevant medical information. But that's what's happened, sadly. Danny has actually written a book, which I've written a foreword to. Actually, we're not even meant to have identified the hospice where the research was done, but anyway, he tells some of these stories of the use of social media and connection in this book called The Comfort of People, which was published earlier this year. Foreword, which we don't need to read. So another hero of mine, actually all my heroes are dead, which is a bit sad, but Kieran Sweeney was a doctor who died of a horrible lung tumour. He reflected in the BMJ on how poor doctors were at communicating with him about what was going on. And he said that doctors had a hesitation to be brave. And maybe we have a hesitation to be brave about using social media and connecting in more creative ways with people. So we've got better at asking questions like this: what matters to you if time is short? But we haven't got better at asking, how do you want to be communicated with? Whether that's text, email, WhatsApp. And actually, as a result of Professor Miller's research at our hospice, when a new referral comes in, we ask people, how do you want to be communicated with? And if the patient says email, text, WhatsApp, Facebook, then that's what we do. Because then you have consent to communicate in that way. I'll move on. So just a few final thoughts about how social media has helped in my experience of hospice care. I remember when I was responsible for raising too many millions of pounds for the hospice, that we did a post just showing that it was the contents of black bags donated to hospice shops that were funding end-of-life care. And this was more powerful than showing a pretty picture of a hospice shop or a shop window, because it made people think, why is end-of-life care being funded by second-hand goods? There are many, that's a big discussion point, but that was just about using a photograph to really bring it home. Safety. There's a key paper, the reference is here when you get the slides, but Barbara Gomez and Vera Sarmento looked at what makes people feel safe when they're being cared for at home. And it's that presence and competence are the things that make people feel safe. And I think presence doesn't need to be face-to-face. I think it can be robust advice lines, and social media contact can help people feel safe. It's about getting instant wise advice, and that's what we need to do. Because, I'm going to whiz through these last few slides because you're going to hear more about virtual reality later. The picture on the right, I asked the patient, how many times were you up in the night last night to take extra medication? And she just sort of clicked on her Fitbit and it came out with a graph showing that she was actually up at 2 a.m., 4 a.m., 6 a.m. And that gave me an instant picture of how bad her pain was overnight. Robots, don't know if we're hearing anything about robots, but they are the future, sadly. And this is particularly for me, single women growing older. I don't particularly want to go into a care home, although I'm very interested in care homes. I might want to share a house with other people who are growing older alone. And so there's big websites in the States trying to join people up. So like a student house, but for Zimmer users. You want to share with people who are like-minded rather than end up on a corridor in a care home not knowing anybody. So just to round off, I've mentioned Alexa right at the beginning, reminding me to change my fentanyl patch. Now, do any of you still work with hospital notes that look like that? This was a set of notes that came from Watford General Hospital when I was working at the hospice. They almost weighed more than the patient. Thankfully now, we have electronic records. So all of that data is in an electronic record. Eventually, we'll be able to ask that data what to do. So Alexa, my pain is bad. So supposing all of that data about your health was input into a program. Anybody watch Black Mirror? Right, okay, we're not far away from several of the episodes in Black Mirror. So Alexa has answered, take 10 mils of Oromorph and ring the hospice, because the data about the medication and the diagnosis and the symptoms are all in there electronically. And Alexa will come up with a good answer, we hope. You're all looking nervous now. You won't all lose your jobs for a while. So I'm very interested in AI and big data and small data. So what you don't know, well you probably do know, is that data is being gathered all the time from your laptop, probably from your electronic health record. Oh, that was the other thing I was going to say about WhatsApp. WhatsApp is less likely to be hacked than the NHS electronic record that you're typing into. And we know from the cyber attacks last year, the NHS. So there we are, that's just a warning shot. So if on your laptop you've Googled back pain, and that's linked up with your electronic record that tells the computer that you're also living with breast cancer, and then you Google legs are tingling, well, Alexa might tell you that you're at risk of spinal cord compression. So we are in such early days now of allowing big data to help us, to prompt us with ideas, and probably to prompt patients. So I don't know if that's scary, but it's certainly what the future holds. So I've already told you all that we're going to become the dying boomers, and we will want to use digital creatively. We will expect to be communicated with openly, transparently, and accessibly. We know that there's a massive increase in the need for palliative care in the future. This is a recent paper. 42% more people will need palliative care by the 2040. I won't still be working in 2040, but looking around here, some of you will be. So there we are, you're going to be busy. Globally, that's even huger, if that's a word. So we need to find ways of supporting people with a light touch. We are not going to be able to see 40% more people face to face. We're going to have to use social media, virtual consultations, everything that's out there to communicate and help people feel supported. And this is just a very recent paper by an MP called Alan Mack, which was commissioned by Jeremy Hunt. He's done the foreword looking at the future of digital in the NHS, and I recommend this. So, I think I am at the end now. So what I've talked about is trying to share power, democratizing our communication, saying you use WhatsApp, I can use WhatsApp, and let's find a safe way to do it. And through doing that, giving back power, control, and raising self-esteem. And the tomato is there to remind us that the tomato is actually a fruit, but you shouldn't put too many in your fruit salad. So we have to use, so the knowledge is that tomato is a fruit, the wisdom, and you'll probably put up your hand and say you do put tomatoes in your fruit salad, so there we are. And a reminder of what Dr. Kieran Sweeney said, this is about stopping that hesitation and being a bit braver in the way we communicate with people. The most dangerous phrase in the language is we've always done it this way. So you do need a social media strategy, and we're just developing one at the Royal Marsden. They've got a very brief one at the moment, which is more about behaving on social media and not putting yourself drunk up on Facebook. But we are developing this into how we can communicate with patients using social media. And that's my last slide. Rachel Munnan. So thank you very much. I've covered too much, but there we are.